Let's talk about subcutaneous injections. As a nurse, probably the most common injections you'll ever give will be sub-Q. If you are giving insulin, and we have a lot of diabetic patients out there, or any kind of an anticoagulant that's administered via injection, it's going to be subcutaneous. That means that no more than 2 milliliters, and it says this on page 45. Other books will say something different, but no more than 2 milliliters is injected into the loose connective tissue. So underneath the epidermis and the dermis, you've got a layer of skin, the sub-Q layer, which is just fat and connective tissue, and that's where you're aiming for. The absorption of these medications is going to be slower because there are fewer blood vessels in sub-Q tissue than in the muscle. And you can see when they represent muscle, it's very dark red because of all the blood supply. The fatty layer doesn't have as much blood supply. It's got some, of course, but not as much as muscle. The placement of a sub-Q injection is going to be at a 45-degree angle. Now, our textbook says 45-degree angle. ATI states 45 to 90. And many times this will depend on how much sub-Q tissue is present. If you are giving someone an anticoagulant in their abdomen, usually abdomens tend to be pretty, rich in adipose tissue. And so you can pinch up more, and depending on the size of the needle, you could go in 90 degrees and still hit sub-Q. If you're unsure, if your patient is very thin, doesn't have a lot of adipose tissue, you're going to pinch up what they do have and go in at a 45-degree angle. So depending on which kind of test, whether it's ATI or textbook testing will go by the book. ATI, you want to remember that it could be 90 degrees if you have more sub-Q tissue. On page 49, you see the sites of sub-Q administration. We've got abdomen, the fleshy back of the arm, not the side of the arm where the muscle is, but the back, the tops of the thighs where you pinch up the skin above the muscle, and then the upper back, although that kind of makes me cringe. What's very important when you're giving sub-Q injections is that you teach the patient to rotate the site. You don't want to be giving injections into the same place over and over and over again. It's bad on the skin, bad on the sub-Q tissue, and it can form scar tissue. So you want to teach the patient a way to rotate their sites. And examples of these could be, you give them a little diagram like you see on page 49 with the skin. Say you give them their first injection in the upper right quadrant of the abdomen. So you'd make a little X there so you know that the next time you're moving to the upper left quadrant. You can also do something called the tape dot system. You can get a little dot Band-Aid, or you can go to Office Max and buy 1,000 of those little dots made for marking things. And you just tell your patient, give yourself the shot, put a dot over that spot. The next time you go to give your shot, just make sure you take off that dot and give it in another area, and then put a new dot. You want to go at least 1 inch from the previous site if you're giving a lot of injections in the abdomen, which you might do with maybe they're getting heparin BID. You want to go 1 inch from the previous site, and in the abdomen 1 to 2 inches away from the umbilicus. Here you're going to use, you might use a TB syringe if you're drawing up your own medications like Lovenox, or not Lovenox, heparin. But many times you're going to give an insulin syringe if it's insulin. You want a needle gauge also that's 25 to 27, and the length can be 1/2 inch to 1 inch. The book will also tell you 5/8 inch to 1 inch. But remember, 1/2 is 4/8, so there's not that much difference between 4/8 and 5/8. but it's going to be no more than 1 inch to go into the adipose tissue. And you can give 0.5 to 2 milliliters of medication, but no more than 2 mils. If for some weird reason you had to give more than 2 mils, you want to go to 2 different sites. And here is another example, besides the one in your book, of what you can do to give an injection. If it's a short needle and not a lot of adipose tissue, you go in at a 45-degree angle. If there's a lot of adipose tissue and an even shorter needle, you can go 90 degrees. It just kind of depends. And you'll get better at estimating. But you can see the 90 degrees is held straight up and down. The subcutaneous is held halfway between parallel and 90 degrees. And then last thing we'll talk about as far as giving injections is IM injections. They're talked about on page 49, and you can see with an IM injection, you're going straight down into the muscle. Now, we will be talking about sites for IM injection. We'll go over this in injection lab. When you rotate through, you want to make sure that you're staying away from A, major blood vessels, B, nerves. Now, the deltoid site, you can usually give about 1 milliliter in adults. Sometimes you will see a book that says you can give 2, but no more than 2. This book says no more than 1. And definitely no more than 1 milliliter in children. When a child becomes old enough that you can give him a deltoid injection, an injection in the upper arm, and usually they're 10 before they can get a small intramuscular injection in their arm, you only use 1 mil. There are advantages and disadvantages to each site, and it's very important that you use the landmarks that you are taught. And in your book, on pages 50 and 51, you can see those landmarks, and of course we will cover that in injection lab. Now, in our textbook, the dorsogluteal, which is just the butt, a shot in the butt, is not recommended in this book because it's close to major blood vessels and close to the sciatic nerve. Now, it's not close if you pick your landmarks correctly, but an untrained nurse or somebody who did not pay attention, didn't listen to lectures, didn't read the material, and was absent the day of injection lab could do a lot of damage. Now, I am still going to teach you the dorsogluteal injection because I think it's a great site, personally. And if you follow your landmarks, you won't hit anything. But the ultimate determinant of, the ultimate decision of whether or not you're going to give a dorsogluteal injection depends on what your facility protocol is. If your facility protocol says no dorsogluteal injections, then no matter how much Mrs. Lohman raves about them, don't give them. It's as simple as that. But I'll still teach you. Other sites, the arm, you can only give about 1 milliliter. Other sites, you can give 2 to 3 milliliters. More than 3 milliliters, you need to divide your doses. Intramuscular injection allows for more rapid absorption and the ability to absorb fully over hours to days, depending on the type of medication. The equipment, 20 to 22 gauge needle, got to be long or fairly big around for the medication. 1 to 2 inches, and believe me, that 2-inch needle will look like a sword. It is, it's really long. You'll look at it and it's like, oh my goodness. Usually 1 to 1.5 inches is sufficient. And then 0.5 to 2 or 3 mils. A needle for children 6 or younger, the vastus lateralis, the thigh muscle, is the largest, safest muscle to give injections to children 6 or younger, and so you're going to use a 1-inch needle. Now, on the next slide, you'll see a diagram and a picture. Most places will have you aspirate. You'll pull back a little bit to determine if you're in a blood vessel, because you don't want to inject most medications that are intended for IM into a blood vessel. Some places are not having you aspirate anymore for whatever reason. Once again, facility protocol. Aspiration is not recommended for vaccines. So if you go to get a flu shot in your upper arm, they're probably not going to draw back, and because they're most likely not going to be in a vein. But in the hip, the buttocks, or the thigh, you need to aspirate and make sure you're not in a vein. All right, the next slide shows an intramuscular injection. This is talked about on page 49, and you can see you're going straight in, and you're aiming to make a pool of medication in that muscular area.